Good morning. At the outset, thank you, Dr. Pandhav sir, and thank you, AIS, for this opportunity. Post-op management, TRAB is the easiest of the things that has been shown, and the problem comes later. So, completion of trabeculectomy surgery really is the beginning of a process that takes several months to complete. The alterations in blood morphology and aqueous outflow due to the scarring response influences the long-term success, and appropriate management at the appropriate time is essential to ensure a filtering bleb, something like this, which we'd all like to see. So what is the ideal trabeculectomy? We'd all like to see a diffuse, mildly elevated bleb with normal conjunctival vasculature, visible fluid in the flap, and yet a scleral flap visible just at the base of it, a well-formed anterior chamber, a tightly closed conjunctival wound, and a patent sclerostomy. Now, isn't that a miracle to ask for? Because you're asking the body to heal completely, heal partially, and not heal at all. But this is the kind of bleb on the first post-op day which we'd all dream to have, and let's see what happens. But that's utopian. And all of us who do trabeculectomy surgery have these usual bugbears to take us through. So how often is follow-up required? I'm often asked this question because they say that every follow-up visit costs money. So that's a question which has been asked time and again. But then you can't get away from it. You do need frequent monitoring if you're going to do a trabeculectomy and you expect it to succeed. Because it allows changes in bleb characteristics to be identified, and there's an early window of opportunity which exists to modulate these changes. And if you lose this window of opportunity, you've lost the battle. So the first 6 to 8 weeks, we would say, are crucial in making your trabeculectomy bleb successful. So what our usual schedule is, we call them weekly for the first month, 2 weekly for another month, and then depending upon the bleb and the IOP. So what is shown here is typically on the first post-operative day, you see it's a diffuse bleb all right, but there's a little bit of bleed, which really goes away by the time of the first week. At the end of 2 weeks, it's better, and 6 weeks later, you can be on your way to tell your patient that it looks as though your blebs are doing fine. But this entire period of time is not just wait and watch. This period of time envisages looking at the bleb and modulating changes as you see. So it's not going to be the same every time. But this is what a usual course would be, because we do very tight suturing. In the first week, there's going to be quite a bit of inflammation. So what you need to tackle is that. So frequent topical steroids and cycloplegics in the first week, and yes, you need to tell your patient that you will not be able to read from this eye for the first month or so, because we are going to be using a lot of cycloplegics to bring down the inflammation and keep the anterior chamber intact. But usually on the first post-op day, the IOP is high because we've done very tight suturing of the scleral flap, because we don't want the hypotony. It's easier to manage high pressures post-operatively than low pressures. So what is usually required is a gentle massage, and I've shown it right there. You just need to go over the top lid, just beyond the scleral flap. So it's a sort of fish mouthing just for an instant. So you just give one quick massage, and that's usually enough. And this, you see, is a flattish looking bleb, and after the massage you can see the fluid. So this is just after, on the first post-op day. And it results in fish mouthing, and just one bead of aqueous comes out, and that's all that you need. So it's better to have intraocular pressure in the mid-teens in the early post-operative period, and not have your eyes hypotenuse to prevent the secondary aqueous from coming and forming your anterior chamber, which is going to be rich in cytokines, and the fibroblastic activity is going to be more. So be careful not to shallow the AC. So be very, very gentle with your massage. You can give 1 or 2 if you want, but just be gentle. Now, within the first post-operative week, usually the bleb is quite vascular. If it's excessively corkscrewed or inflamed, a subconjunctival 5-fluorouracil injection is given under aseptic conditions. So this is probably within the first week, and that's where the injection is given, way away from the bleb, but be careful. There is a risk of injection 5 going into the eye if your eye is too hypotenuse and if you inject it fast. So be very, very, very gentle. Be right away from the bleb, because you just want that 5FU to percolate down in the area of your bleb, but you don't want it inside. Now this is something which I'm not proud to share, but it's happened. I was too fast probably, and this poor guy suddenly became white as I was injecting it, and your heart is in your mouth when you do something like that. You don't really know what to do. Somewhere in your brain thinks, oh God, now I'm going to land him into a keratoplasty. But this is 1 week later, and 6 weeks later, thankfully, he did clear. But it's very, very scary when it happens. So this is just to show you that you need to be very careful while doing these procedures. The other thing is when to manipulate sutures. Well, intraocular pressure is still high, or if there's a lot of pressure required for massage, it's best to do a releasable suture removal, and it's prudent to do it within the first 10 days to 2 weeks before the scleral flap starts scarring down, because then if you remove it later, probably the suture might break, and then you're in trouble because then you need to use a laser or something to lysis. So we usually do it within the first 3 to 5 days when the pressure is really high. And it's easy to just catch hold of this loop. All these blebs are Fornix-based flap, because that's what I usually do. But either of them, with the Limbus-based flap, they work extremely well. And then you just need to take a sterile forceps, put in a drop of paraffin, and just pull out the loop, and you're through. So this is what a typical course would be in young patients. Day 1, all we need to do is give lots and lots of steroids for the inflammation. By day 7, usually they've had their suture removals and their injection 5FUs in place. And by day 21, this bit of corkscrewing the conjunctiva is already becoming normal and on its way to becoming a good bleb. Now what if the pressure is low? Now that is more troublesome than if the pressure is high. Look at the bleb. If it's high with a shallow AC, it's probably due to overfiltration. You need to initially give it just a good pressure patch, atropine, and if there is a lens and cornea touch, you need to reform the anterior chamber. But low with or without a shallow AC, look for a leak. That's most important, and as Dr. Mangia showed that conjunctival retraction on the post-operative period, do a Seedles, look for your leak, and the way to do the Seedles is not to put in a drop of fluorescein, but take a dry strip of fluorescein and just paint that area of the bleb, and then look for a leak. And if it's there, that needs to be sutured immediately. Of course, with all low ACs, look behind for a choroidal or a retinal detachment, because those are things which might be overlooked and could be causing your low pressures. Now, trabeculectomy can be very frustrating. And I came across this wonderful study, really, published in the BGO, and I suggest all of you who are doing trabeculectomy should read it. But I'm putting it here. They looked at 119 trabeculectomies with a minimum of a year's follow-up. 78% required some form of bleb manipulation, which means that what we're doing is not wrong. 49% of blebs needed a massage on day 1. 49%, nearly half, required at least one suture removal by day 7. 31%, that's 1/3, required one 5FU injection by the time it was 2 weeks. And 25%, which is 1/4, required at least one needling and 5FU injection by an average of 43 days, which is about 6 weeks. So post-operative intervention is frequent after glaucoma surgery, and we can't get away from that. It requires an intensive post-operative follow-up. It's a labor-intensive undertaking. Doing the trabeculectomy is easy, but salvaging the trabeculectomy bleb is tough. IOP in the intervention group, in spite of all this, was always higher than in the group that did not require an intervention. So what should one look for? There are several indicators that point to a risk of bleb failure. One is, of course, excessive conjunctival injection. If it's very, very red, you need to be a little worried. Corkscrewing of vessels, as Parul said. The corkscrewing vessels on the surface just means that the fibrosis is occurring just below the conjunctival surface. And those fibroses are pulling those vessels, which should have been straight, and that's why you need to be worried. Because you need to intervene right then, make those fibroblasts go away so that that scarring can be reversed. And it can be reversed only in the first early post-operative period. If there's a high bleb phase, it's important to recognize that, and that occurs if your pressures are high. If your pressures are high, ask yourself why. Don't just go in and accept it, and don't just do a knee-jerk reaction and put in a timolol or put in an anti-glaucoma agent. Ask yourself, why should your pressure be rising after the bleb? It's important to recognize a high bleb phase, which typically happens at 6 weeks, and conversely requires an aqueous suppressant to tide over that period and prevent it going into a tenon cyst. If there's flattening of the bleb, there's inadequate filtration, consider needling. And if the IOP is still high, do a gonioscopy, look at your sclerostomy. Many times you would have something blocking the sclerostomy. That's one iris pillar blocking it, half of it is patient. But you must look at the cause of what is happening, only then you can intervene in time. So in summary, the trabeculectomy is a beginning of a process aimed at achieving a satisfactory bleb morphology and satisfactory intraocular pressure control. But for some trabeculectomies, the post-operative period may involve many interventions. Each of the various interventions has a specific role, either in isolation or in combination. Recognition of bleb morphology is the basis of intervening in time, but it's a sobering fact that despite close monitoring, some trabeculectomies